The COAPT trial was presented first at TCT last year. It's a study on secondary mitral regurgitation in patients with heart failure that were already on optimal guideline-directed medical therapy that included drugs and biventricular pacemaker whenever appropriate. That study randomized patients into two arms. An arm was the interventional one, where patients received the MitraClip, edge-to-edge approximation to decrease mitral regurgitation, and the control group was guideline-directed medical therapy. So both groups received guideline-directed medical therapy optimized, and one added to that the MitraClip. The results of that study were actually striking in that the MitraClip group fared significantly better to the primary outcome, which was heart failure hospitalization at 1 year, with a number needed to treat of about 3.7 or something similar. But the secondary outcomes were also significantly better on the MitraClip group, and that included overall mortality and the composite endpoint of mortality and heart failure hospitalization, all of them with a really low number needed to treat of 4.7 to 6. So that's what COAPT has told us. As you very well know, at a similar time, a few months before that, MitraFR was presented, which in theory was a very similar study on a similar population. However, results were exactly opposite. So it really brings up a question as of why is it that these studies are so different? And while we did not address that question in our echocardiographic outcomes study, we did decide that it was very important to provide details of how patients qualified into COAPT, because if people in the clinical practice can replicate what COAPT did, then we probably are targeting the right population. So the first part of my presentation this morning at ACC here in New Orleans was about describing the screening criteria from an echocardiographic standpoint. How did we define moderate to severe or severe mitral regurgitation, which was the inclusion criteria for this trial? And we did that with a study-specific multi-parametric algorithm that used not only PISA, or effective regurgitation orifice area by PISA, but also used pulmonary vein flow reversal, vena contracta, regurgitant volume, regurgitant fraction, and a few other variables. So patients had different ways of qualifying in the study. But the bottom line is, while the protocol and the algorithm was very specific to the study, it was an adaptation of the American guidelines. And that is a difference with MitraFR, because MitraFR was mostly derived from the European guidelines. So there may be a difference there as of which patients were enrolled in one study and the other. Again, we did not compare that in this report, but we do believe that by providing such a detailed description of how patients got enrolled and what their baseline characteristics were, we probably can bring some light into that question of who is going to benefit from MitraClip. The second part of our analysis was actually looking at all those baseline echocardiographic characteristics and try to identify who were responders or non-responders to MitraClip therapy. And it was very interesting to see that when we broke the population into halves based on being above or below the median for each of the echocardiographic characteristics, all the subgroups that we analyzed actually did better with MitraClip. So in other words, we probably failed to find non-responders to this therapy. I think if we have to circle the whole message of the presentation today and the echo sub-analysis within COAPT, that one would be that if we include the right patients, the patients that were included in COAPT, and we follow the guidelines that we did in this study, then all patients will be part of that population that benefits from the MitraClip. Again, it's a specific population. There were a lot of inclusion and exclusion criteria, but it's definitely worth looking into those in detail when we make our clinical decisions, because there is an opportunity to benefit our patients.